Thank you very much, Dana, and lovely to hear your voice again after a couple of days. Thank you very much for having us. We've both flown over from the Southern Hemisphere. It's a really long way away, so we're delighted to finally be speaking today. Christine and I are going to be addressing the topic of nutrigenetics and nutrigenomics in estrogen metabolism. How do we really looking at what are the estrogen-related conditions and what are these topics of nutrigenetics and nutrigenomics in terms of treatment protocols? There are 4 parts we're going to be swapping over. I'm going to start off with an introduction. Christine's going to be taking you through cellular processes in estrogen metabolism. I'll be jumping back in again about nutrigenetics of estrogen metabolism, and Christine will be finishing off with the nutrigenomics. And in a few slides, I'll just define exactly the difference between them for those that aren't comfortable. Just as a disclaimer, both Christine and I have co-authored 2 translational nutrigenomics courses under Manuka. I also have a nutrigenomics center in South Africa, and Christine has a company, CellLogic. What were our learning objectives were really to understand the upstream pathways that are involved in estrogen metabolism. We want to get to grips with what are the key variants, the key polymorphisms that really drive estrogen metabolism and modulate the pathways. And then we really want to think a little bit about what are the biomolecules, which ones are these nutrition-derived molecules that would influence the metabolism in a nutrigenomic manner. So just to start off with, and there's been some discussion already today on how much does genetics play a role, how much does it matter? And we're all very familiar with what we call the Angelina effect, which is really the BRCA genes. BRCA, it's BRCA1 and BRCA2. And the first talk of the day also touched on this idea that there was only a small group of gene variations that really accounted for the big breast cancers. And when I talk about the big breast cancer, we're talking about this concept of high penetrance gene variations with low penetrance gene variations. And I think the one thing that I would like to clarify just from this morning's talk is the difference between these two. Because what we know is that about 5% of breast cancers occur because of what we call the high penetrance gene variation. So exactly like a BRCA gene. If you have the gene variant, your risk of contracting breast cancer in your lifetime is between 80 to 90%, and the impact of diet and lifestyle and exercise and environmental exposures is going to be fairly minimal. However, the reality is that the other 95% of breast cancers are extremely complex conditions, and this was alluded to. They're not just epigenetic in nature. Of course, they have an epigenetic component. Of course, they have a diet, lifestyle, environmental exposure component. But the other significant component of the other 95% is gene variation. It's these gene variants that we call low penetrance. In other words, by themselves, the variant does not cause the disease in any way. And there is always an interaction with an epigenetic mechanism: diet, lifestyle, exercise, toxic exposure. It's this low penetrance gene variations that Christine and I are extremely interested in terms of trying to modulate disease risk and create interventions. And this great slide on the gene ontology of cancer was really quite informative when you think of the complexity of the condition. So when we're looking at something like breast cancer and we're thinking about what are the genetic variants that would modulate or play a role in the process, we can look at something like this and start thinking about all the different touch points in the biochemical processes that drive cancer that we need to consider. What is the gene? Are there SNPs? Are the SNPs functional? Do we need to understand them? Okay. Today, I've highlighted some very key gene variants that are extremely common in the nutrigenetic commercial tests that are available in the marketplace. They're the ones that have the most research on, and they're the ones that have been highlighted in terms of their role in breast cancer development, and I'm going to talk about them a little bit more in detail in a few minutes. Before I hand over to Christine, I just want to mention one very important thing. The way that Christine and I teach and practice is based on what we call the 3 pillars: nutrigenetics, nutrigenomics, and nutritional biochemistry. By themselves, they cannot exist. We cannot study nutritional biochemistry without studying nutrigenetics, without studying nutrigenomics. Nutritional biochemistry, I'm pretty sure you're all familiar with. It's really what are the key biochemistry that drives our metabolism. Christine's going to be dealing with a lot of that today. Nutrigenetics is when we have DNA sequence change. It's our gene variants, it's our deletions, exactly what was spoken about this morning, where there's a variant. Some people call it mutation. I prefer to not use the word mutation. It has a negative connotation, so I never use it. But it's really a sequence change. And the third element is what I call where the magic happens. It's where the really good stuff happens, and that's nutrigenomics. Nutrigenomics is how do we take diet, lifestyle, exercise, supplements that we can modulate gene expression to be able to empower the body to be able to heal itself. And this is where NRF2 comes in and NF-kappa beta. So when everything that we do and the way that we teach, it's important to remember that we never look at nutrigenetics in isolation of nutritional biochemistry and nutrigenomics. This is really the key that we talk about. We're very interested in upstream processes. We're very interested in cellular defense mechanisms and understanding the 3 elements of nutritional biochemistry, nutrigenomics, and nutrigenetics, and how they fit in to these upstream processes. I'm now going to hand over to Christine. Okay, I think we can go past that.
So let's have a look at what we're really trying to achieve with modulation of estrogen metabolism. So ideally, what we're trying to do is look at the estrogen or the estrones, the estradiol, and the catechol metabolites of estrogen because they target mammary tissues, and we know they increase cell proliferation in mammary tissues and other tissues as well. And that process whereby we see alteration in the DNA is what initiates the cancer process. So what I want to look at is what these processes mean and how we can modify them. Because our ultimate goal, even though Yael doesn't like the word mutation, but our ultimate goal is to minimise the formation of DNA mutations. And to achieve this is extremely complex because it requires balance at a number of different levels. So we need to look at the estrogen versus progesterone balance, although I'm not addressing that today. We need to look at phase 1 and phase 2 detoxification processes because that plays a really critical role. We look at hormone synthesis versus its metabolism. We look at activating versus deactivating enzymes, methylation versus demethylation, and mutation versus DNA repair. So there are many processes, and balance is critical on at least 7 levels. So how is estrogen associated with cancer? Well, the standard model looks at the estrogen receptor, which really is responsible for about 2/3 of breast tumours. It involves the estrogen receptor in a way that enhances proliferation of cells of all types. The metabolite paradigm, which covers the other remaining 1/3 of cancers, is influenced in the outcome, and it tends to minimise the DNA mutation process. And so if we can influence that, we will be able to address at least 1/3 of the cancers. So one of the ways that we can deal with the estrogen issue and the cell proliferation is that if we can modify the synthesis of estrogen, and the CYP19 or aromatase gene and enzyme are what govern the level of estrogen synthesis, and of course there are drugs which influence that process. We can also influence at the level of the estrogen receptor, and that's where the drug tamoxifen tends to be utilised quite effectively in treatment for a time, but then it can become resistant as time goes by. So that now gives us 2 potential avenues for our clinical intervention. First of all, we can look at the synthesis of estrogen, and we can block estrogen synthesis to prevent receptor binding. and that, of course, is back to the aromatase enzyme. And that's going to reduce cell growth and excessive proliferation. And then the second mechanism is to influence estrogen metabolism. And so the metabolism is an area which I think is not particularly well addressed to a large extent in a lot of clinical circles in which I move. And I'll show you what I mean by that in a moment. So you will be familiar, I would imagine, with the 2-hydroxy pathway, which produces estrogen metabolites. That then involves the COMT gene and enzyme in order to methylate those metabolites and safely remove them from estrogen activity. And that tends to inhibit the process of tumour initiation. The other pathway then is the 4-hydroxy pathway, and that also is involved with COMT, very similar metabolic processes, and that is the one that really causes large-scale DNA damage. And that's the one that's tending to produce DNA adducts, which are harmful and potentially mutagenic and carcinogenic. So what happened to the 16-alpha hydroxy metabolite that we hear so much about? So if we just have a look at the way estrogen is metabolized, we see that from the estrogen receptor, we produce these metabolites via particularly the CYP1A1 phase 1 enzyme, and that alters gene expression in a way that tends to reduce cancer cell proliferation and also to increase cancer cell apoptosis. So that's what we would consider the more desirable pathway. It still produces DNA adducts, but they don't have the same potentially harmful effect that the 4-hydroxy DNA adducts produce. So when we then look at CYP1B1, which is the other phase 1 enzyme, we then tend to produce the 4-hydroxy metabolites, which are definitely mutagenic and damage DNA. Where does 16-hydroxy fit in? Well, it's metabolised by the CYP3A4 phase 1 enzyme, which is the enzyme which is responsible for the metabolism of about 50% of drugs. And while it still covalently binds to proteins and to DNA, it has much less effect on DNA damage. So much so that a lot of researchers are challenging this concept of looking at the 2 to the 16-hydroxy estrogen metabolite ratio. And Dr. Ercole Cavalieri from Nebraska Medical Center has published about 200 papers on estrogen metabolism. And you'll see one of his papers in a moment. But he says that the hypothesis implies a correlation of high levels of 16-hydroxy estrogen with induction of breast cancer. But over the years, this hypothesis has never been substantiated. In 2009 and 2011, other researchers came to exactly the same conclusion, in that the 2 to 16-hydroxy ratio is not particularly meaningful, and it's really the 2 to 4 ratio that we should be looking at. So let's just take a look at how estrogen is metabolised, and this is adapted from Cavalieri's papers. So we see on the left, the estrone or estradiol becomes hydroxylated, and then through a series of steps forms highly toxic semiquinones and quinones, and both of those are what we call the toxic intermediates. So when you hear that phase 1 often produces toxic intermediates more toxic than the initial compound, it's these semiquinones and quinones that we're talking about. Ultimately, if the quinone gets to attack the DNA, that produces these DNA adducts that we're trying to minimise. So how this works then is phase 1 kicks in right here at the beginning and does the oxidation modification via 1A1 or 1B1, and then COMT comes to the rescue at the very first point and causes the formation of methoxyestrogens, which are then metabolised through UDP glucuronosyl transferase, which is another of the phase 2 enzymes, and that safely eliminates it from the system. However, COMT cannot always adequately deal with all of the estrogen metabolites presented to it. So we then go through another step to the semiquinones, which are partly mopped up, if you like, by superoxide dismutase. We then continue on. If SOD can't adequately deal with it, it's presented to glutathione S-transferase, which requires glutathione, and that produces the glutathione conjugates. Now, there's another step involved in this because sometimes still we have excessive quinone estrogen metabolites which are still going to attack the DNA. And what the cell very cleverly does is now takes those quinones, takes them right back to present or represent to COMT to go through the cycle yet again. And that's an enzyme called quinone reductase, which is a very potent phase 2 enzyme that we often don't hear about by name, but which I want to talk about further in the second section. Now let me hand over to Yael.
Thanks, Christine. So basically what I've done is we working with the estrogen metabolism that Christine's just shown you, where we're interested in these different metabolites as they move through the system, that we want to be able to understand how effective is our estrogen metabolism. One of the things I've done is identify what are some of the key gene variants that obviously have achieved a high level of scientific and clinical validity in the literature that would be useful for us to be able to give us some insight into an individual's dysfunction or function in terms of estrogen metabolism. This is just a paper where they basically said that these gene variants played a role in the estrogen metabolic pathway, that what they do is they alter the exposure to their sex hormones and therefore can affect the risk of postmenopausal breast cancer. So I have this Barbie doll kind of person here, and the reason that I do is when I work with these kind of gene variations, I talk about the concept of pop stars. So that's why I've got my pop star there. And so what I've done is I've taken the initial list that I gave you, and I've identified which are the pop stars in this metabolic process. And because we haven't got much time today, I can't go through all the SNPs, so I've really identified my pop stars. Pop stars are generally extremely well researched. They're very functional. In other words, that the gene variant results in a very clear and significant change in enzyme activity. They've been duplicated in their studies, and we know exactly what they do in their biochemical pathway. We also know that when we interact with these gene variants, it's extremely clinically useful, and that all those things together kind of give us a pop star status. So I'm going to touch on just a few of my pop stars and just give you some ideas about why we use it in clinical practice so much and why it's so relevant to us. The first is COMT. COMT actually is a methyltransferase. It's extremely important in terms, well, actually a whole lot of areas. It's one of the really big ones: estrogen metabolism, neurotransmitter metabolism, phase 2 detoxification, methylation. So we really are extremely interested in what happens to this gene variant. When you have one copy of the gene variant, we see a decrease in the COMT activity, but certainly the homozygote has a significant decrease in enzyme activity. It's one of the more difficult genes to upregulate, and I think Christine will touch on that in her part. So it's very important for us to have a look at, because as Christine showed, it is almost the first step in terms of estrogen metabolism, and if we've got a decreased activity. The other thing is we always look at MTHFR when we see a COMT gene variant, because what you need to do is really maintain methylation status when COMT is not working at its absolute best. Glutathione transferase is actually a family of gene variants. GSTM1 is probably the most powerful. It's the real pop star for me. It's a deletion. So if you have the variant, it actually results in a complete deletion of the enzyme and has no activity. That's the bad news. The great news is that there's a family of genes in GSTs, and we can upregulate the family of GSTs using sulforaphane and cruciferous vegetables to compensate for the deletion. GSTM1 is obviously an extremely important phase 2 detoxification gene. It usually manifests quite a great deal in clinical practice, and what we want to do is we want to make sure that we can conjugate our toxins that are coming, or quinone metabolites in the case of estrogen metabolism, and clear them from the system before they have a chance to create DNA adducts. MTHFR, the infamous MTHFR, is not just about cardiovascular disease and homocysteine. It's obviously an extremely powerful gene in terms of the literature. It's still only one gene variant, and it's still only a low penetrance gene variant, so we must be careful not to overreact to MTHFR, and certainly not to overreach in terms of our methylation and how many methyl donors we give our patients. But it has been associated with breast cancer risk, and that's part of that initial metabolism where you've got COMT and we've got MTHFR right next to it. As Christine alluded to, quinone reductase, which is actually NQ01, and there's the gene variant, 609CT, a homozygote of quinone reductase means we have a significant decrease in the enzyme activity of quinone reductase. And as you saw in the diagram of the metabolism, this can severely decrease the ability of the body to recycle quinone metabolites and give it another go at being able to get rid of them out of the body. So there's certain things that we really want to pay attention to: coenzyme Q10, vitamin E, around NQ01 when we see gene variation, not to mention exposure to estrogens, and exogenous and endogenous. Okay, there's really just, now you can see the picture of kind of what Christine proposed and where I put in the SNP. So this is what we talk about: nutritional biochemistry, nutrigenetics, nutrigenomics. We have a biochemical pathway. We put in the gene variants that we know about. You can see COMT is there, NQ01, GST, and of course the other one I didn't mention was manganese superoxide dismutase, which is all about oxidative stress, which needs to mop up those quinones. What's really great in the literature recently, more recently, is the ability to kind of group these gene variants. And what the literature is showing us, that these low penetrant gene variations by themselves are extremely difficult to make clinical decisions around. And it's something we should be very careful of. And it's one of the problems with commercial tests, is this concept of SNP-based recommendations. I have an MTHFR 677, this is what I'm going to do. No, that biochemically does not make sense. What we want to be thinking is, how do the gene variants fit into the biochemical pathway? What gene variants am I working with? Okay. And then what is a pathway-based recommendation that deals with the whole pathway? So doing exactly what Christine has proposed, she's got a pathway of estrogen metabolism. We've identified where the gene variants fit. We look at the whole pathway in context when we're trying to decide what to do with our patients. This is one of the papers, CERN, which is one of the best ones, where they looked at CYP1B1, COMT, and MSOD, and in fact they also had GSTP1, and said, what are these individual SNPs doing, and how do the combinations of these SNPs impact the risk profile of the individual? This is another paper where they looked at COMT and CYP1B1, so a phase 1 gene variant and a phase 2 methylation gene variant, and they found that those that had the homozygous for COMT, those that were either heterozygote or homozygous for CYP1B1, had a higher level of the DNA adducts that were caused by the estrogen metabolites. Okay. I'm now going to hand back to Christine, who will finish it off for us.
So, you've seen this pathway now several times, and let me point out that it's exactly the same metabolic pathway that a lot of environmental pollutants go through. So the blackened benzoate pyrenes that are on your favourite barbecued steak are going through exactly this same pathway, worth remembering. So if we just highlight these genes again, so we've got the phase 1 genes, the cytochrome P450s, the COMT, superoxide dismutase, glutathione S-transferase, glutathione, and that means glutathione synthesis, so we need to be sure that the genes that are upregulating glutathione synthesis are also active, and of course quinone reductase. Let me just go, no, I won't go back. Okay, so if we want to look at optimising COMT activity, if you've tried to look in the literature to find what activates COMT, given that this is something that we should be focusing on, it's quite difficult to find specific activators of COMT. There are papers that talk about quercetin inhibiting COMT, but you need to be very mindful of that because they're in vitro studies, so we don't have a lot of hard evidence in vivo on what either up or downregulates COMT. So SAMe, S-adenosyl methionine, is a methyl donor, the universal methyl donor, so it's going to be active there with COMT. In these pathways involving methylation, one of the intermediates is S-adenosyl homocysteine, which has a direct inhibitory effect on COMT. So this may not be a nutrigenomic intervention from the outside, but it's something from the internal metabolism. And we also know that homocysteine itself is highly oxidative. So it's useful to remember when we're talking about methylation, we're also talking about redox balance. And when we look at the various processes involved in upstream regulation of cellular defense processes, we need to think about redox balance at the same time that we're thinking about methylation. Because as Yael just inferred a moment ago, let's not focus entirely on methylation when we're talking about estrogen metabolism. There are some misconceptions, and the misconception that I frequently see is that phase 1 is being addressed using cytochrome P450 enzymes, and then methylation is considered to be phase 2, but then it stops there. And as you already saw, there is a whole series of other steps which we need to consider when we're looking at how to safely stop estrogen adducts from being formed, and the often overlooked NRF2 target genes are the ones involved. So you heard plenty of discussion this morning about activating NRF2 target genes, and the ones we've talked about in this metabolic pathway, GST, quinone reductase, UGT, and the glutathione synthesis genes, are all NRF2 target genes. So if you can upregulate NRF2 itself, then you have a tool, a very powerful nutrigenomic tool for influencing estrogen metabolism. And so the phase 1 to phase 2 ratio that's based on just looking at CYP1B1 and COMT is really quite incomplete. Here's just a nice 2013 diagram to illustrate some of the NRF2 target genes. So there's NRF2 in the middle. Up on the top right, quinone reductase, glutathione production, another series of NADP production enzymes. And so we have this whole process that we need to investigate if we're going to satisfactorily deal with estrogen metabolism. So how does NRF2 do that? Well, essentially, it starts with some sort of a weak pro-oxidant which acts as a stressor to the cell. And that stressor is then detected by the cell, and that then starts the machinery which starts the production of the NRF2 target genes. So essentially that weak pro-oxidant filters through the system into translocation of gene expression, and so we produce the genes that we're looking for. This summary here says there are about 500 cytoprotective genes. This was published in 1994. It's now closer to 2,000 since further research has been done. So where did this whole NRF2 story start? NRF2 was not discovered until 2004, and back in 1997, a group of researchers just up the road here at Johns Hopkins University looked at this concept of broccoli sprouts as being powerful inducers of these phase 2 detox enzymes. And they looked at the induction of quinone reductase in particular as being a very powerful strategy for achieving anti-carcinogenesis. And so what they say in the lower section of this abstract here is that sprouts of many broccoli cultivars contain negligible quantities of indoles, which predominate in the mature plant, but may give rise to degradation products such as indole 3-carbinol that can enhance tumorigenesis. So it's very controversial looking at the indole 3-carbinol and the DIM, which is a metabolite of indole 3-carbinol, because they're highly dose dependent. So they're preventive against cancer at low doses, but they can actually be carcinogenic at high doses. So something to be mindful of. Back to quinone reductase, which I call the best kept secret in nutritional medicine. because an extensive body of evidence supports the conclusion that quinone reductase protects cells against detoxification effects of redox cycling of quinones, the depletion of glutathione and the development of neoplasia. And what this paper from 2000 doesn't also say is that quinone reductase is a very powerful agent for recycling coenzyme Q10, which is ubiquinone, there's a quinone moiety, recycles oxidised vitamin E back to the reduced form, does the same thing with vitamin K. So it plays multiple roles as part of the whole cell defence system. It's also been considered by some to be a cancer biomarker, and in some papers they talk about a CD value in relation to quinone reductase, and it's a way of evaluating various activators of NRF2 to establish how comparatively potent they are. So as we've seen, if we want to protect cells against carcinogenesis, we need to regulate phase 1 versus phase 2 so that the ideal detoxifier tends to downregulate phase 1 processes or ignore them entirely and upregulate phase 2. So in 2007, a paper was published by the Johns Hopkins group that looked at the comparison of quinone reductase induction with other common phytochemicals. And as you can see here, when we're looking at not just sulforaphane, but we're looking at quercetin, curcumin, beta-carotene and so on, all the way up the list to chlorophyll, you'll see that sulforaphane is the most potent activator of quinone reductase. The second most potent, penostrobin, you may or may not have heard of. It's the active compound in galangal, which is a rhizome that looks a little bit like turmeric and is used in Asian cooking. So because sulforaphane is the most potent inducer of quinone reductase, it obviously becomes an intervention tool of significance. Now, part of my PhD research is in sulforaphane, and in fact that's its major focus. And so what we did is we extended that comparative table further, and we looked at the various agents which have been documented as upregulating quinone reductase, and we see ascorbic acid has no value in doing this. Chlorophyll, which is often sold in health stores, in Australia anyway, as a detoxifier, and lots of people go after the chlorophyll supplements thinking that they're detoxifying. I don't know where that stemmed from. Chlorophyll has some other benefits, but quinone reductase induction is not one of them. Chlorophyllin, which is a synthetic version of the same thing. Then we go through some other common supplements, curcumin, dim, silymarin, or St Mary's thistle, and so all the way to sulforaphane. So the other side of the equation that we always need to consider when we're looking at nutrigenomic interventions is not just what an in vitro lab study shows us, but really the bioavailability of that compound. It's not much use a compound being highly potent if it's not also bioavailable. So when we're looking at percentage bioavailability, we're essentially looking at how much of the compound that I ingest actually ends up in my cells where it can have an effect. So when we look at this diagram here, we can see again that sulforaphane is highly bioavailable compared to the other molecules. And the structure of the molecule becomes fairly obvious here as being part of the reason. The sulforaphane on the bottom right is a very small lipophilic molecule that glides through membranes readily, whereas the others are all big, bulky polyphenols which have less opportunity to be taken into the cells. So when we look at where sulforaphane comes from, a speaker this morning said there's no sulforaphane in any food whatsoever. And if you find a supplement perhaps that says it contains sulforaphane, it does not, because what the supplement actually contains is a precursor compound called glucoraphanin and an enzyme called myrosinase, and that reaction is going to be activated by cutting, chewing, or in some way bringing those two compartments of the plant cell together. And when that reaction occurs, that's when you produce the sulforaphane. Sulforaphane is not very stable. It's got about 30 minutes to 60 minutes at most once it's produced. So you need to be actually having that reaction going on inside your system and not in a jar of juice or such like. If the myrosinase is absent, then you will not produce any sulforaphane. And that's a very important point to note, because even light microwaving will destroy the myrosinase enzyme completely. Boiling most certainly will. And I know there's commentary on light steaming, but we have no idea what light steaming really means, because it destroys it pretty quickly no matter what you do to heat it. Myrosinase actually is at its enzyme optimum at 60 degrees centigrade, and you're boiling at 100 degrees, you're steaming at 100 degrees, you've killed that enzyme very quickly. So I think we need to be sure that we're having intact myrosinase in any supplement that we might take. So we've illustrated that point, but the problem with a lot of the supplements that are available, and there's been reference to this throughout the entire conference here, is that a lot of the supplements have no myrosinase in them at all. They've in fact been deactivated so that the supplements contain significant levels of glucoraphanin precursor, but no enzyme. And the theory is then that the gut microflora will substitute for that myrosinase activity. Now that's true to the point of about 8 to 10% of the myrosinase activity that you get in the native plant. If a patient has just had a course of antibiotics, we probably don't have any, we don't know really what species of microbiota have this myrosinase-like activity. So it's pretty hit and miss. The trap that you can easily fall into is that the supplements which are only the extracts will have on the label, this contains so many milligrams of sulforaphane glucosinolate. Now that's not a chemical term at all. But as soon as you see the word sulforaphane, you're going to think it's going to be active in sulforaphane. So a bit of a trap for the unwary. A number of researchers have been extremely concerned about the fact that the sort of people who are going looking for a sulforaphane yielding supplement probably have cancer or some other serious chronic illness, and so they want to be sure that they're buying something that's going to do the job. So in 2011, Clark and his research group looked at comparing a supplement which contains sulforaphane glucosinolate, or just the extract, versus the opportunity to in fact use a whole broccoli sprout supplement which is myrosinase active. And his conclusion is the consumption of broccoli supplements devoid of myrosinase activity does not produce equivalent plasma concentration of bioactives compared to the fresh sprouts. And also says this has implications for people who consume the recommended serving size of one pill, believing that they are getting equivalent doses. And there have been a couple of other researchers who've published similarly, being aware that this is a huge trap for the unwary. Sulforaphane acts in a dose-dependent manner, so it's very important that if you're looking for a sulforaphane-yielding supplement, that you're actually getting the number of milligrams of sulforaphane that are needed. Now, I don't have a slide for this, but when you evaluate the 40 or so clinical trials that have been done on sulforaphane and or broccoli sprouts over about 20 years, you'll see that for most conditions, it looks like about 18 to 20 milligrams a day was the intervention dose that produced a positive outcome. It's about 40 milligrams for type 2 diabetes, and there's one study done that looked at prostate cancer which needed 60 milligrams. So you need to know that you've got a supplement that's actually capable of delivering those doses. Otherwise, if we don't get the appropriate dose, we're not actually achieving anything. You're not going to then reach a threshold that's activating NRF2, which is then going to lead to the expression of those NRF2 target genes. A couple of speakers have earlier talked about epigenetic effects. So when you're looking at the dose response for sulforaphane, the NRF2 activation happens at the lower doses. The epigenetic effects actually happen at the higher doses. So it's important to know what you're trying to target when you're dealing with this. So some nutrigenomically active options in modulating estrogen metabolism, you will have this slide in your notes. So I don't want to go through the whole thing in great detail, except to say that vitamin D is a very good aromatase inhibitor. The drugs that are being used as aromatase inhibitors are not ideal for a number of reasons. If you want to downregulate CYP1B1, it's usually the diindolyl methane or the DIM, which is recommended to not so much downregulate CYP1B1, but to improve the CYP1A1 to 1B1 ratio. So you're trying to steer your estrogen metabolites down the 2-hydroxy path and not down the 4-hydroxy path. Interestingly enough, another study that came out of a different research group at Johns Hopkins has shown that sulforaphane actually downregulates CYP1B1, but it's not through NRF2. There's another otherwise unknown mechanism which is allowing that to occur, and sulforaphane also upregulates COMT, again through a non-NRF2 mechanism. We talked earlier about the downregulation of COMT using quercetin, but then that's questionable because they're only in vitro studies. I'm sure you know about phytoestrogens in inhibition of sulfation, so that's kind of doing the tamoxifen thing and blocking the receptor. Numerous polyphenols are shown to upregulate the NRF2 target genes, but as you might have remembered from the bioavailability slide, those big bulky polyphenolic molecules often don't get into the cells. So what's happening in vitro is not necessarily what's happening in vivo. Now, if you eat a food which is very high in plant foods, you will get additive effects of the various polyphenols in a whole host of different foods, and so you can get NRF2 activation. But if you're looking for just a polyphenol supplement, you probably will not get adequate to have an effect. So again, always important to look at where the bioavailability allows this to sit. And as a bit of a side issue from what I'm just discussing right now, I do want to comment on that in relation to the ketogenic diet, because the question I have with a ketogenic diet is, where do I get all my plant foods now that are going to produce this whole array of phytochemicals that I am arguing are necessary to deal with metabolism, not just estrogen, but the whole environmental toxicant issue? So I don't have the answer to that question, but it's one that I pose for you. And of course, then we're talking about upregulating the target NRF2 genes. Interestingly enough, when we're talking about indole-3-carbinol DIM, the DIM, or the I3C, is produced in the mature broccoli vegetable and not in the sprout. And the sulforaphane is produced from the sprout and not so much from the mature vegetable. So questions that we get about thyroid toxicity and indoles doesn't really apply to the sprout. But interestingly enough, to eat enough raw broccoli vegetable to be the equivalent of a 100 milligram DIM capsule, you'd have to actually eat 3.5 kilograms of the vegetable. Is that 7 pounds or something like that? Yeah. Which is not very practical. Now, Yael and I, in our teaching, tend to take a food-first approach. We tend to like supplements where it's practical to consume that amount of food to get the end effect. So we tend to avoid supplements which are highly concentrated extracts of something which may occur in nature, But of course, supplements like DIM and I3C are not produced in nature, they're produced in a lab, so they're synthesised. So just imparting a few points worth considering. Equine estrogen metabolites are highly used in the pharmaceutical world, but they can inhibit phase 2 detox enzymes, glutathione S-transferase and quinone reductase, so that may have some implications. Women also using equine metabolites with SNPs of homozygous COMT may be at increased risk. And what are the implications then for who knows how many millions of women are using oral contraceptives or some other form of estrogen replacement? And so with those parting thoughts, we'll close this seminar.